are nothing but your ethmoidal cells. The ethmoidal cells, if they are placed more anteriorly, they'll push your frontal sinus drainage pathway posteriorly. If they are more based posteriorly, they'll push your frontal sinus drainage anteriorly. Is this clear? So when you see your scans, you're supposed to see your sagittal scans and then decide. You'll sometimes see us curating from back forwards, from the skull base. Take your instrument, curate, and come forwards. That's when your cells are more anteriorly placed. If your cells are more posteriorly placed, start from front, go towards the frontal recess and draw them back. So that's how you uncap the egg, either front to back or back to front. Is this clear? So you can figure out all of this from frontal cells. You have to figure out. Now I'll talk to you about the configurations again. So that's the frontal recess. Here again in the coronal section you'll see this. This is frontal recess. So previously you saw a thick chunk of bone over here. The very next cut where the thick bone vanishes and you can see this area, this is called the frontal recess. Is this clear to everyone? Here you can see the middle turbinate attaching itself here to the junction between the medial and lateral lamella of cribriform. You can see the nasolacrimal duct. You can see over here the agar nasal cell just down here. Okay, you can make out the frontal beak, frontal recess, and frontal sinus. Anyone feels I need to repeat it, please put up your hand. I will repeat it. Okay, please, this is not a one-way lecture. I want you to understand this. So if you all don't understand, please put your hands up and ask, and we will be happy to clarify any doubts. Now this, in one of the cuts earlier, you'll start seeing this grayish area over here. This is nothing but the nasolacrimal duct. Alright, where does the nasolacrimal duct open? It opens under the inferior meatus. In the inferior meatus, under the inferior turbinate. Okay, I'll show you that as we go in. Now, Kuhn's classification of frontal cells, I already showed you how the cells are there. So, what is Kuhn's classification? You have an agar cell. You could have one cell, you could have two cells. If they are all in this area, they are called Kuhn type 1 and 2, right? If you have a cell, which is, this is a single cell, that's Kuhn type 1. Two cells is Kuhn type 2. If you have a cell which is going into the frontal sinus, but not going more than 50% of its height, that becomes a Kuhn type 3. And if you have an isolated frontal cell, this becomes a Kuhn type 4. Correct? Now, why was this classification made? Just for fun? No. The idea is these cells are all removed endoscopically, correct? If you know there is a Kuhn type 3, you go inside over here and you can do a sort of a little bit a draft procedure, draft type 2B for example, and then take out this cell as well. Okay, you don't want to leave this cell there. And if you have a cell which is isolated and this harbors disease, then you have to think of different ways you can go, because you cannot go for it endoscopically only. So then you have to think of different procedures like DAF type 3 or external procedures like, you know, external frontal trephines and whatnot stuff. Is this clear to everyone? So this was the reason the classification was made. For you, what you must understand is not necessary to define as type 1 or type 2. You know there are cells down here. You need to clear up these cells so that you're clearing the frontal sinus drainage pathway. Alright? You should not leave behind the cells. And you should remove it knowing it. So don't just take a suction and just put it there and it smash the cells. Don't do that. Dissect it off in such a way that you get a smooth frontal recess without damaging the mucosa. Is this clear to everyone? Okay, this is the advantage. And if you have a Kuhn type 3, you have to go into this area, but you will require a wider area. Your suction will not be able to reach this Kuhn type 3. So then you would require something like a 2B and then go and sort of put a instrument and curate in and then take this down. This you will not be able to do it endoscopically. Okay. So again, the same things on a scan. So this is agar nasal. This is one single cell which is Kuhn type 1. You can see over here on the right side there are two cells which is Kuhn type 2. Then here you can see a cell which has gone into more than halfway up the level of the orbit here. This one. This is Kuhn type 3 and isolated cell is a Kuhn type 4. Is this clear to everyone now? Alright, good. So now coming back to this. This again I did not know. This is my fellow who taught me this. It's a very basic way to understand. You see cells over here. Sometimes I ask my resident what cells are these, and they'll be looking twice before they figure out it is anterior ethmoidal or posterior ethmoidal. So round orbit plus triangular maxillary. The maxillary sinus means you're in the front over here. Maxilla is triangular over here, right in the front. So you can just about see the maxillary sinuses coming up. This is the nasolacrimal duct over here. So if you see this triangular maxilla and a round orbit, he says it is anterior ethmoidal cells. Okay, simple way. It's just a small trick, nothing else. But you need to understand it closer to the cribriform. Okay, so again, anterior ethmoidal cells over here. That's the middle turbinate. Important for you to see where the middle turbinate goes and attaches. Madam has already given you a lovely lecture as to the attachments of the middle turbinate, how it attaches to the cribriform, how it attaches itself or forms the ground lamella and attaches itself to the lateral nasal wall. So you need to understand those attachments of the middle turbinate over there. This is the nasolacrimal duct, round orbit and triangular maxilla. So here what you're seeing is nothing but the anterior ethmoidal group of cells. Clear? So initially what you have the agar cell, then you have the ethmoidal cells. These ethmoidal cells, in varying configurations, they obstruct the frontal recess, right? Is that these cells which form the Kuhn type 1, 2, and so on and so forth, right? So when we are talking of, say for example, let's say we are talking of polyp surgery, okay? So when we say we are doing a polyp surgery, no problem, come. When we say we are doing a polyp surgery, someone says, oh, don't touch this frontal recess. Frontal is not involved. Don't touch the frontal recess. Okay. There was a big man in India who said that actually. So I said, what rubbish are you talking? Isn't it the anterior ethmoidal cells which are pneumatizing it into the frontal recess? Okay. If you're not going to clear the frontal recess, how can you say you finish your ethmoidectomy? You cannot say that, right? You're defying the logic of doing a polyp surgery by not clearing the ethmoidal cells, by not opening the frontal recess. So even in polyp surgery, the idea is to open up and clear the openings of all the sinuses so that there is good ventilation and you can have your drug delivery reaching everywhere. Okay, so in polyps, pure polyps located bilaterally in the ethmoidal sinuses also, you still have to clear the frontal recess, because until you do that, your ethmoidal cells are not cleared. Okay, and it's going to recur back. Is this clear to everyone now? Okay, so this is a very common question asked. Will you touch the frontal recess in polyp surgery? Of course I will. Even if it is not involved, I have to clear it. Otherwise I'm not doing a complete surgery. Alright? So anterior ethmoidal cell variations. You see this over here? Some cells over here. This is called the Haller cells. Okay, you can see this Haller cell over here. Just at the opening, this is the uncinate process over here. You can see this just obstructing. If this Haller cell is becoming big or inflamed, it's going to obstruct the drainage pathway of the maxillary sinus, right? So this is the uncinate process and this is the drainage pathway of the maxillary sinus. Again here, this is a Haller cell. This is pneumatized crista galli again, okay? Not to be touched, not to be run after. Supraorbital cells. Now what is a supraorbital cell? You know you have your frontal recess, behind which there is one cell, and then you have your anterior ethmoidal artery. We all know this, right? Frontal recess, I'll repeat, one cell and the anterior ethmoidal artery. Now suppose that cell is a blind cell. It's called like a terminal recess. But if that cell pneumatizes over the orbit, it's called a supraorbital cell. Clear? So here you see this. You see here a cell going right over the orbit. Now this supraorbital cell is generally posterior to your frontal recess. So in your cuts, don't get confused. Someone saying, oh, this is frontal sinus. No, this is not frontal sinus. So your frontal sinus comes in the more anterior cuts. You'll see your frontal recess. And after your frontal recess, if you see a cell like this, you know it's a supraorbital cell. Clear? So this is behind or posterior to your frontal recess. This is called the supraorbital cell. So this supraorbital cell could be small. It could go way and pneumatize all over the orbit over here. Clear? Sometimes you get disease into this, and there are various approaches you can do to this, reach that area. Clear? Now here, whenever you get a supraorbital cell, you know that one cell behind the anterior ethmoidal artery, I told you, is there, right? But when you get a big pneumatization of that cell, then your anterior ethmoidal artery could lie into mesentery, right? Normally the anterior ethmoidal runs across the skull base. There was a cell and it's running along that cell on the skull base, posterior border of the cell. But suppose its cell itself is pneumatized. What happens? The anterior ethmoidal artery runs into a mesentery and the cell pneumatizes supraorbitally. Is this clear? So you have to watch for this into the in your scans to see where the anterior ethmoidal artery is. So if you know your anterior ethmoidal is running in a mesentery, be careful when you're approaching the skull base behind the frontal recess. Whether your approach is front to back or back to front, you must know that the anterior ethmoidal artery will come up now and it will be lying in mesentery. And then you should be careful not to use a debrider over there, because you snap it and then you're gone with your anterior ethmoidal and then you'll end up with complications. Okay? Olfactory fossa. Now again, when you see your scans, you study this olfactory fossa. Quiros was the one who classified them into 3 types, 1, 2 and 3. The measurements are written here, 1 to 3, 4 to 7 and 8 to 16. Okay? Why did he classify this as 1, 2, 3? Just because he wanted to make himself famous? Okay? So he did this because this gives you a prognostic feature how likely you are to damage the cribriform during a surgery, right? The deeper the cribriform is, the more likely you're going to damage it going into the frontal recess. Can you see this? Here frontal recess will be far off. Here you see this is the area you have to go. This is the turbinate attachment. You have to go into this area to go into the frontal recess, correct? Here you see when you're going and trying to clear off these cells, your lateral boundary is your cribriform, lateral lamella of cribriform. So you're more likely to damage it as the cribriform becomes deeper compared to when it is flatter. This is the prognostic implication of the Quiros classification. Is this clear? So you need to understand where your cribriform is, study that on the scan as well. Right? So again, the same things on a scan. These measurements are taken. This is done on the DICOM. We take the measurements just to give you an idea of how the type 2 and type 3 distances are. Okay? If I see this, now you see this area over here, this is the frontal recess area. Can you see this? So the frontal recess, if you really want to understand the boundaries of the frontal recess, this is frontal recess. What are the boundaries of the frontal recess? I say, or you have heard even probably Satish saying it, right? Don't worry about which cells. What are the boundaries? You are worried about where the frontal recess is. You're poking as a junior person. You don't know where it is. Always see the attachment. If your turbinate is attached here to the junction of the lateral lamella and medial lamella of the cribriform, your frontal sinus is always lateral to the turbinate, correct? Now when you're going into this area, anterior most limit is your frontal beak. You already know that, correct? Laterally, what do you have over here? Lamina papricia, right? Medially, what do you have over here? Lateral lamina. And posteriorly, what will you have? A blind cell. So you have 3 or 4. So that's where the intact bulla technique came from. If the intact bulla goes up to the skull base and you keep that intact bulla, that's your posterior boundary. Okay? So once you know the boundaries, you're not worried about what cells these are, right? You just go and clear it. You are going to be surely in your frontal recess if you stick between the orbit laterally, lateral lamella of the cribriform medially. So when you take your suction, you don't go straight on like this towards the, or you won't go like this towards the, the lateral lamella. What you go is you take your suction and go a little bit here into this groove. You have to watch this opening and go into this area. If you go here, you're going to damage this and cause a CSF leak. So the boundaries of the frontal recess again is laterally the orbit, then medially you have the lateral lamella, okay? Anteriorly you have the frontal beak. Now you're doing a revision surgery, for example, and you just don't know, there's a lot of scarring in that area. The one landmark which will take you to the frontal recess is your frontal beak. So palpate your frontal beak, and where the frontal beak disappears, if you put your suction, that's going to be your frontal recess. Okay, that's a very easy way, but a most sure way to do things. Is this clear to everyone? Everyone cannot afford a navigation. Use this frontal beak as a landmark. So if you know one landmark, okay, I always keep saying, if you know one landmark, your other landmarks follow, whether it's the temporal bone or the sinus. In your house, once I give you a wall to touch, you know exactly where you are, you can follow your rooms keeping your eyes closed. So exactly that should be the thing over here. You see one structure, oh okay, I found the frontal beak, I know my lateral lamella is going to be on this side, and I know my orbit is going to be on this side. You should be very well versed with all these landmarks. Okay? Then lacrimal apparatus. So lacrimal apparatus, again, madam has explained and showed you lovely bony osteology of the same. She showed you the lacrimal bone, she showed you the frontonasal process of the maxilla, and how the lacrimal the nasolacrimal duct opens into the inferior meatus. You've seen that, right? She also talked to you about the Hasner's valve. So again, how do you see this on the scans? If you see the scan, you see this grey structure going in here. This is the nasolacrimal duct. Okay, you'll see it on both sides over here. And where did this open? Somewhere here. You can see just a bony area, but this is where it opens into the inferior meatus. Okay, right up, as she said, towards the axilla. That's the nasolacrimal. Okay, and that's the valve fastener which she says, and that's the inferior turbinate. So middle turbinate attachments. So she's already told you, but let me again reflect back on what it is. So normally, many cases, you see this middle turbinate. This middle turbinate goes and attaches there to the skull base. Okay, most often you will find the middle turbinate attaching superiorly to the skull base, right? You also see paradoxical turbinates. Can you see this turbinate which is curved paradoxically? Most of the turbinates are turning medially. This is almost laterally, right? Then this is partial pneumatization of the turbinate. This is paradoxical with pneumatization. This is concabulosa. This is clear? So all the middle turbinate variations are there. All of them attached here now to the skull base, right? So but this is a bilateral paradoxical turbinates that you can see over here. You can see secondary middle turbinates, and you can see a huge concabulosa on this side, very big concabulosa. So this sort of turbinate, normally we prefer not to touch the turbinate much, but this sort of turbinate prevents you from doing surgery on the inside. So we access it and try to reduce it only to gain more access, to decrease the bulk of the turbinate. It's not diseased, it's clean, but sometimes to gain access we have to do a conchotomy and take out this to gain more access. So again, where is uncinate process attached? You see this uncinate process is the first thing. It can be attached anywhere. It can be attached to the lateral nasal wall, it can go up, etc. So when you put the scope in, the first thing that you're looking for is this uncinate process, correct? We all know where the uncinate is, right? Madam already told you superiorly to inferior. She already showed you the two limbs going down there to the inferior turbinate area. Now, why do we have to take off this uncinate? Because only when you go with a backward forceps and take this uncinate out, can you open up the whole infundibular or the hiatus semillunaris. Till then, all those ostia are hidden within that groove. So that groove is formed by the uncinate. So there you see uncinate going there. You see the red mark coming over here, uncinate. Okay, and that uncinate is going and attaching up there. Can you see that? It's attaching to the skull base. That's the variations in the uncinate attachments. So the same things are shown on the scan here. This is one. If you just stick to this, I won't show you the same thing on these scans. Just stick to this. This uncinate, can you see this blue over here? How is it going? It's going towards the orbit. Okay. This is another uncinate going like this towards the orbit, and there's one cell on top of it over here. Okay, this is an uncinate which is going bilateral, like going like a Y shape. This is an uncinate going towards the skull base. This is again an uncinate going towards the skull base, and sometimes it can go towards the middle turbinate. Now, the frontal sinus, if you read a chapter on frontal sinus, they will always talk to you about attachments of the uncinate and the agar, and how they change the drainage pathway for the frontal. Okay, so why uncinate is important? Because you should know how to take off this uncinate, and then you understand where your frontal recess is in attachment to your uncinate. For example, this is the uncinate attached here. So where will your frontal sinus open? Medial to the uncinate, correct? If the uncinate is attached here, where will your frontal sinus open? Lateral to your uncinate. So the uncinate needs to come out, and when you take off the uncinate, you need to take it off right till the top. Okay? Many people take out the lower half and leave the attachment to the upper half. You have to remove the upper half and the lower completely, and lateral to your uncinate is going to be the orbit. Okay, that's why they say go a retrograde method to bite the uncinate and take it out. Don't go with the forward. If you go forward, if you take a sickle knife and cut on the uncinate, I think Sujata may show you that. If you take and cut the uncinate, then you're likely to enter into the orbit. That is why you palpate it. Take a ball pen probe, palpate the uncinate and bite it backward to forward. Okay, you all know using a backward forceps how to take off the uncinate. So this is the reason why you do the uncinate retrograde method. So I'll just skip on this. So it was trying to show you all this attachments. Okay. Coming back, you earlier saw me showing you a round orbit and a triangular maxilla, right? So again, this is a very rough way of saying things. This is triangular orbit. Can you see this orbit getting a little triangular? As this orbit goes backwards, it gets smaller. Earlier you see it round, and as you go down, it becomes a little bit triangular in shape. So triangular orbit with an oval-shaped maxilla. Earlier you saw maxilla head was almost triangular. Here is an oval-shaped maxilla. So that's posterior ethmoidal cells. If you see this plate of bone over here like this, you know for sure that these cells here are posterior ethmoidal cells. Okay. What are you seeing in addition? You're seeing your inferior turbinates, the back end of the inferior turbinates. Where is it going? Attaching to the lateral nasal wall. Right? So already madam showed you the anterior attachment is to the skull base, but the posterior attachment is to the lateral nasal wall. Correct? So this is your attachment to the lateral nasal wall. Here you see this is the middle turbinate over here. Okay, coming here, and this is sorry, this was the inferior turbinate. I made a mistake there. Sorry, this is the middle turbinate here. You see it coming here. It will just go back there, and this is the posterior ethmoidal cells over here still. Is this clear to everyone? So here the posterior ethmoidal cells over here, and same thing showing you the superior turbinates over here and maxillary sinus which is oval. Just telling you what I just showed you. As you go a little bit behind the posterior ethmoids, okay, I've already shown you the superior turbinate. Madam showed you how the lower end of the superior turbinate uncovers the or is blocking the sinus ostia, sphenoid sinus ostia. Correct? So right behind your turbinate you will see a sphenoid sinus. Right? So this sphenoid sinus, now you have already studied that this is the choana. Madam showed you that pretty nicely. The lateral wall of the choana is what? Medial pterygoid plate. Can you see this pterygoid? This is the medial pterygoid plate, this is the lateral pterygoid plate. Correct? So the medial wall of the choana, lateral wall of the choana is your medial pterygoid plate. Okay? Normally, you don't get so much of pneumatization. If you get a pneumatization of this area of the sphenoid sinus, it's called the lateral sinus, right? So medial and foramen rotundum are sometimes here next to each other. But if there is pneumatization between the Vidian and the foramen rotundum, and this pneumatization involves the pterygoid base. This is the pterygoid base. Okay? Pterygoid base, medial and lateral pterygoid. So if it pneumatizes this pterygoid base, this is called the lateral sinus. Is this clear to everyone? Clear? Say yes. Yes. Okay, good. Now, what do you need to see in a sphenoid sinus? Right? This is extremely pneumatized. You need to see the septations. Where the septations go. The septation could go towards the optics. Septation could go towards the carotid. Septations could be thick septations, thin septations. The idea is never twist and pull on these septations. Always drill it out. So you have proper drills. Drill out all the septations. 2. You're going to look at the optic nerves and look at whether there are dehiscences of the optic nerve. Right? If the optic nerve is very well into bone, then you don't need to worry. 3 is pneumatization of this area. This is called the lateral OCR. Right? This is the anterior clinoid process. So if there is this pneumatization, you'll find a deep opticocarotid, lateral opticocarotid recess. If there's no pneumatization, your carotid and your optic will be very close. You will not find a very pneumatized anterior clinoid process. Is this clear to everyone? So all this you're going to observe in the sphenoid sinus itself. Okay. You get lateral sphenoid leaks coming from here. Sorry, 1 second. Hello. Yeah. I had told them to call the patients after 4:15. Okay. I will reach only after 4:15, 4:30. I had told yesterday just made I will reach only by 4:15. Let them come, but I'll reach after 4:15. Okay. 4:15 or 4:30. Okay. So that is all about the sphenoid sinus. Then coming down to Onodi cell. So you have to identify your scans when the posterior ethmoid pneumatizes into the sphenoid. Alright? Then your optic nerve lies in the Onodi cell rather than lie in the lateral wall of the sphenoid sinus itself. So you have to study this on your scans. Okay? You can see this quite clearly. You'll see the Onodi cell like this, and you'll see optic nerve in the lateral wall of the posterior ethmoid. So you have to identify this on your scans again. So here again, if you see the sphenoid, this is your opticocarotid recess, lateral OCR, what we are talking of. I was talking to you about this. If the anterior clinoid is pneumatized, you get a deep opticocarotid recess. If it's not very pneumatized, you get a shallow opticocarotid recess. Okay? When you look at this whole this thing, sphenoid sinus, this is the region of the sella. You can see the region of the intersphenoidal septum over here. You can see this is called the sella. This area below this wall of the cella or the cellar bulge, this area is all called the clivus. Okay, the area just between this sphenoid and this planum here, this is called the tuberculum, and ahead of that is the planum. Now on this picture everything looks straight, it's not like this. The sphenoid, I'm just using this as a example. This cella is like a bulge. Okay, junction where this starts turning anteriorly, this will be planum, that is cella. The junction there is the tuberculum. So it's not exactly like this, it's something like this. So this will be cella, this will be tuberculum, and this will be plenum. This is clear to everyone? That's where it goes ahead. So you have various approaches. For the pituitaries, we do only cellar approach. For the tuberculum cellae meningiomas and craniopharyngiomas, we do a much larger approach, which goes into the tuberculum transplanar approach. Okay. Again, optic and carotid. Now, what is the orientation of the carotid over here? Okay, you can see this carotid bulge like a C-shaped thing and coming down here and then turning from here, right? So this is nothing but the paraclival segment of carotid. This is the anterior genu bend. This is the circle, posterior bend, and once it goes into this, it goes into the intracranial segment. Is this clear?
So can you repeat?
Okay, this is the paraclival segment. Okay, the cavernous segment starts somewhere here. If I draw a horizontal line over here somewhere, okay, this is called the petrolingual ligament. So somewhere if I draw a horizontal line over here, up till here, this segment will lie within the cavernous sinus. Okay, but here to understand it, you have to understand the carotid is behind. It comes forward over here. That's why I said this is an anterior bend. It comes forward. So it's like if I am the carotid and y'all are operating, this carotid is not going to be like this. Carotid is going to be like this. So this paraclival carotid comes like this and turns. So this is like a cobra facing you. The sphenoid cavernous segment is more towards you than the paraclival segment. Got it? This is the way my carotids would be, like this. Is this clear to everyone?
Optic nerve?
Yeah, this is the optic nerve over here. So if you follow the orbital apex, you see this optic nerve coming over here. Till here, it's all extracranial. Once it goes, you see this thing disappearing here, it is intracranial over here within the CSF. So even to do optic nerve decompression, you can decompress only till here. Beyond this, if you do, you're going to get CSF leaks. Everyone clear about this? So this is how all this translates. Now here you're seeing the intersphenoidal septum. You're seeing the anterior process. This is not a very pneumatized anterior sphenoid process, and you can see the sphenoid sinus. Again here, medial pterygoid plate, lateral pterygoid plate. This is the pterygoid wedge. Okay. The pneumatizations of sphenoid, conchal pneumatization, nothing at all there. Okay. Pre-cellar is just ahead of the cella. Incomplete cellar is like this, and this is post-cellar going way behind the sphenoid sinus. So many a time when we do pituitary surgery, we have one of these configurations. Rarer to have these combinations, but if you have these combinations, then you need to drill out. If I need to take a cellar tumor or a pituitary tumor out, I need to drill out all this bone over here till I get an access, or I create this cavity deeper to the cella. Okay, so in pre-cellar, I would have to drill out a lot of this clival bone to access this. In the conchal type, don't do it in your initial phases. You probably require navigation or other things to do it with. So don't try to attempt this in here. Most often we have this situation or this situation where we are seeing the bulge and this bulge comes into the sphenoid. But even here, I would still need to go behind till here. So I would still need to drill out a little bit more of this cellar base. This is the best situation here. Okay? So you understand the areas. Okay. Now this is the cellar bulge. Like I told you, this is the tuberculum and this is the planum sphenoidae. This is called the posterior clinoid, and all this is the region of the clivus. Alright? So in summary, when you see the scans, you need to study the scans front to back, and you need to see all these structures where everything is attached. If you're going towards the frontal sinus, you must know what is the configuration of cells. You must know what are the boundaries of the frontal recess, and sometimes you get even very small non-pneumatized frontal sinus. So don't poke your instrument into those areas. You know that there's no frontal sinus or very small, just a dimpling over there. Don't run for that frontal sinus. Okay, if you have a very pneumatized frontal sinus, you know my suction will go in. And with your suction, you cannot go into the lateral wall of the frontal sinus. So if you have disease, sometimes you use irrigations. You irrigate and the whole thing, because the polyp is not going to go inside the frontal sinus and sit there. Polyp is just going to block the ostia there. So once you take out the polyp, if there are secretions or if there is fungus inside, for example, you need to irrigate the sinus and clear the sinus out. Okay, am I clear about this? So all about frontal. Ethmoids, I already told you, be very careful, study the configuration of your skull base and go and clear out the ethmoidal cells. Uncinate, I already talked to you. Middle turbinate, I've told you, we don't do anything much to the middle turbinate. And maxillary sinus, I think everyone knows. Once you take off the uncinate, it's pretty easy to identify the maxillary ostia and widen it. And again, in surgery, surgical aspects, we'll teach you what is the maximum limit you can widen this maxillary sinus ostia, or how you widen the sphenoid sinus ostia, and so on and so forth. I think that will all be in the surgical. So everyone clear about the scans thus far?
Onodi cell in CT scan.
Pardon?
Can you show the Onodi cell in CT scan?
Yeah, this is the Onodi cell here. Okay? You will see this very prominently in your sagittal scans. When you see a sagittal scan, you'll see the posterior ethmoid actually going there, and also on your axials. This is an axial area. Can you see this here? This is an Onodi cell. You see, this is a proper sphenoid sinus, but this is an Onodi cell. Same thing if you depict this here, see this. This is what it is. Got it? If here again you can see, you make out this is sphenoid sinus. Okay? This is an Onodi cell over here.
How can I differentiate which one is sphenoid, which one is
Okay,
Onodi?
Okay, let me show you this film now. Where's that? Okay, like this. For example, this. You get this sort of intersinus septum and you get a horizontal ledge over here. When you start getting a horizontal ledge, like for example, take this ledge. Can you see this ledge? This. So be aware this could be a posterior ethmoid. Why? If you consider this as a sphenoid, your posterior ethmoid like a cone is going into the sphenoid. Right? And there's a cell partition, horizontal cell partition. So this could be this could be a partition within the sphenoid, or it could be a Onodi cell. No? This could be an Onodi cell, correct? So this you have to match with your axial and sagittal scans to say this is posterior ethmoidal cell, or sorry, Onodi cell. Got it? So just seeing this is not good enough. This could be just a septation in the sphenoid, but this should give you an idea. Yes, probably this is an Onodi cell. So when you're seeing your coronals and if you see this horizontal septation, understand that this could be your sphenoid sinus, but this could be your posterior ethmoidal sinus itself, and this is your full sphenoid sinus, you can see. Clear? So this should give you a suspicion of an Onodi cell. But yes, you will have to match it on axial scan and see whether your sphenoid and your posterior ethmoid are separate. And on your sagittal scans, you will see a clear posterior ethmoidal cell going there and sphenoid below it. Okay? So that is why you need to study scans in all three dimensions.
Frontal beak in CT scan.
I showed you that, no, in the beginning. Showed you that. So this is the frontal beak here. Can you see this here? This thick bone here is the frontal beak. So once this disappears, okay, then you get the frontal recess. Clear? So you'll see that, and if you see it on the sagittal scan, see this. This is what it is, thick beak over here, and this is your line where it is. Behind that, it will be just a black area, which is the frontal recess. Alright? So if you do it like this, you will not find a problem. Alright? I think later in the afternoon there are some scans. We'll try and show you some other scans on all three dimensions. But this is just to teach you what all to see on the scan. Is that okay? Any questions? Okay.
Thank you.
So I think we go on with the next lecture. I think Sujata is supposed to come in. I just send a message to her.